dehiscence, whichever way you wish to pronounce it, this bone goes missing and leads to a third window effect, causing a pseudoconductive hearing loss, and more importantly, causing vertigo in patients secondary to a loud sound or pressure changes and so on and so forth. But do pardon me for the fact that I do not have a clinical image for this particular scenario. And uh, and then now I come to one of my favorite topics, and that is Meniere's disease. And once again, I beg your pardon for the fact that I will not be able to show you clinical pictures, but in my opinion, there has been a lot of development as far as Dr. Solara. There are some people in the waiting room, and they need to be admitted probably.
Okay,
I'm
okay.
getting a message here. Yeah. So uh, at least my reading of the literature has shown me that there's been a lot of development as far as imaging in Meniere's disease is concerned, and that is why I thought that even though I do not have the images, it would be nice and prudent if we can discuss what those developments have been. And I'm sure a lot of you are familiar with those developments, but still. So Meniere's disease, you see the routine T1 weighted images, the routine T2 weighted images, and the routine contrast images are actually not sufficient for diagnosing. Let's not talk about Meniere's disease for helping us visualize endolymphatic hydrops. Okay, so there is a certain protocol that is being promoted these days. There is a certain protocol that is being promoted these days, and I will talk to you about those protocols. But the first thing that we need to know is that the blood-brain perilymph barrier is permeable to gadolinium-based contrast medium. It is permeable to gadolinium-based contrast medium, whereas the blood endolymphatic barrier is not. The blood endolymphatic barrier is not, and the perilymph endolymphatic barrier too is not permeable to the gadolinium-based contrast medium. And why should this become important would be evident to you in a little while. So the first message here is that the blood perilymphatic barrier is permeable to the gadolinium-based contrast medium, but the blood endolymphatic barrier and the perilymph endolymphatic barrier is not. That's the first basic idea that we have to have in mind. What does this lead to? You have the perilymph, right? And because it is permeable to the gadolinium-based contrast media, the perilymph containing cavities of the otic capsule, that is the scala vestibuli, the scala tympani, the bony vestibule, and the semicircular canal are hyperintense. And because they are hyperintense, they appear white, but when on some specific protocols. These protocols are the 3D flare, delayed 3D flare, and I'll come to that delay later on. It's a heavy T2 weighted 3D flare, or a heavy T2 weighted 3D inversion recovery sequence. But again, more of that from your radiology friends. So because the perilymph is permeable, these structures appear hyperintense, but because the endolymph is not permeable, the scala media, the utricle, the saccule, and the semicircular ducts, they appear hypointense, and that is black, dark on an MR, on those special MRs. Okay, so can keep that in mind. This is just a representative picture. This is not the actual protocol picture after contrast. This is just a representative picture. This is the vestibule. This is the posterior semicircular canal. This is the basal turn of the cochlea, middle and the apical turn of the cochlea modulus. You can actually see the interscalar septum here, and you can see the osseous spiral lamina extending from here. Now, if we do the image as per the prescribed protocol, the images are much better, and you can actually see the osseous spiral lamina. But still, the basilar membrane, the further extension of the osseous spiral lamina as the basilar membrane. But I hope my friends who are listening to this presentation are able to make out this slightly hypo-intense shadow here within the body of the vestibule, and the shadow here. So this is the saccule, and this is the utricle. Okay, so this is where we have to pay attention if we are following that particular protocol of MR imaging, following the use of gadolinium-based contrast media. This is the saccular area, this is the utricular area, this is the osseous spiral lamina, and then you have the basilar membrane, and somewhere here is the scala media. Okay. A lot of publications have come in, especially from the Nagoya University. And this is the gentleman who's been at it for the last 20 years, Professor Shinji Naganawa, who's been advocating who's been actually working on the visualization of endolymphatic eye drops in patients with Meniere's disease, and even otherwise. He's got publications of a demonstration of endolymphatic eye drops in patients with enlarged vestibular aqueduct, and so on and so forth. So they have proposed two methods of means of use of gadolinium. One is the obvious IV method, but the other is the intratympanic method. The advantages and the disadvantages we'll discuss later, but the two methods, the obvious, the IV method and the intratympanic method. But more important than that is that what they have advocated is a delay as far as imaging of the patient is concerned. Normally, what happens when the patient is subjected to an MR imaging, the patient is given the contrast media and the patient is immediately imaged. But for the demonstration of endolymphatic eye drops, if the patient has been given the GBC, the gadolinium IV, they are asking for a 4-hour delay. And if it is intratympanic, they are suggesting a 24-hour delay. Okay, so intratympanic gadolinium, a 24-hour delay, and in IV, a 4-hour delay, and there are specifically protocols designed to helping us visualize the utricle, the saccule, and the scala media better, because end of the day, endolymphatic eye drops is a disease which involves these compartments rather than the perilymphatic compartment. Okay, the detailed protocol you can see talking about the 3D real inversion recovery, and they're talking about the heavily T2 weighted 3D flare protocol, the details of which are available in these papers, and you and your radiology friends could always refer to these papers. Now, before we go to what is it that we need to visualize if a patient is subjected to one of these two protocols, we need to know that what are the pros and cons of an intratympanic use and the intravenous use. Obviously, because we are using the gadolinium intratympanically, the chances of it reaching the perilymph are higher. Basically, it's the same principle that is used for gentamicin therapy in refractory cases of Meniere's disease, right? The idea is that the gadolinium is going to percolate through the round window into the perilymph and cause a hyperintense shadow. But remembering from our first slide on this topic, because the perilymph endolymph barrier is not permeable to gadolinium, the gadolinium is not going to percolate from the perilymph into the endolymph. So the perilymph will be hyperintense, but the endolymph will be hypointense. Anyway, and it is the difference between the perilymph hyperintensity and the endolymphatic hypointensity that we wish to look at and evaluate in order to diagnose endolymphatic eye drops. So it is the fact is that if you give intratympanic gentamicin, the perilymphatic enhancement is much more compared to the intravenous. But obviously, the intratympanic gadolinium is invasive, because however minimal it might be, you need to puncture the tympanic membrane, but you need not. It is non-invasive as far as the IV use is concerned. While gadolinium-based contrast medium is obviously approved for IV use, it is an off-label use of gadolinium. So maybe in some of the countries, our friends would not be able to use it for intratympanic use. The other important part is asking to the patient to come back after 24 hours, whereas in case of intravenous gadolinium, it's a wait of 4 hours. Again, the contrast enhancement or the visualization of the endolymphatic eye drops secondary to the contrast enhancement is only localized to the side wherein you've injected the gadolinium as far as the intratympanic modality is concerned. But in an intravenous, you have the advantage of visualizing both the sides together. So here you have to be very, very sure that you're actually injecting the side wherein you're suspecting the Meniere's disease or the endolymphatic eye drops. Again, as far as intratympanic injection is concerned, you need both the radiologist and the otologist, whereas the IV can be done by the radiologist alone. And the last confounding factor here is that in an intratympanic gadolinium use, similar to that of gentamicin, the condition of the round window membrane also decides how much of the gadolinium is going to percolate, is going to diffuse into the perilymphatic compartment. compartment. If the round window is thickened, if there is granulation tissue, if it is thickened because of an inflammatory process, the diffusion is much lesser. Okay, now Naganava and the entire series of publication, they have given us a gradation of the endolymphatic eye drops, which has been modified by Barath and Bernard's later on. But the endolymphatic eye drops, as seen according to their protocol, let's look at what they are saying. You actually study the vestibular area separately and the cochlear area separately. And in the vestibular area, you look at the ratio. What is the ratio? You measure the entire endolymphatic compartment. You measure the entire fluid compartment of the vestibule, that is perilymph plus endolymph. Okay, and from there you see how much of the endolymphatic compartment is being occupied, what percentage of that endolymphatic compartment is being occupied by the hypointense shadow. So that gives you an idea as to whether the endolymphatic occupation of the vestibule is within the normal limit or not. Normally it is said to be between 26 to 30%. So they have proposed a 1/3 occupation by both the utricle and the saccule. Mind you, it has to be a combined value of the utricle and the saccule vis-a-vis the entire fluid compartment. So if it is less than 1/3, it's a grade 0. But if it's more than 1/3 but less than 50%, it's grade 2. And if it's more than 50%, it's grade 3. On the other hand, in the cochlea, I do have some animations for you. So we'll go on to that. If there is no displacement of the rhizoid membrane, then it's a grade 2-0. Mind you, the osseous spiral lamina is a bony structure. It cannot go down. So it's the rhizoid membrane which is actually going to bulge into the scala vestibuli. So if there is no displacement of the rhizoid membrane, it's grade 0. If there is partial displacement of the membrane, but the area of the cochlear duct, the scala media, is not larger than the scala vestibuli, it's grade 1. And finally, if the area of the cochlear duct is more than the scala vestibuli, it becomes a grade 2. So let's quickly look exactly what are they saying here. Okay, so this is a representative sketch. So let's look at the cochlea first. So this is the modulus. This is, say, for example, the basal turn of the cochlea. Normally, even with the modality that they're proposing, this is the scala vestibula, scala tympani. Normally, the scala media is very, very small. The area occupied is very, very small. And it's sometimes not, it's more often than not, it's not visible even with the protocol that they are suggesting. So this is hypointense. Please do imagine that this entire area is hyperintense after following the protocol that they've been advocating. So this is totally hyperintense. This is the osseous spiral lamina with the basilar membrane. This is the rhizoid membrane. So under normal circumstances, this is what you would have as far as the cochlea is concerned. And this is the bony vestibule. This is the area of the saccule, and this is the area of the vestibule. So here, there is hardly any displacement of the rhizoid membrane, and here the composite occupation by the saccule and the utricle of the total vestibular volume is less than 50%, less than 30%. Okay, the scala media becomes wider, wider volumetrically, as a result of which the osseous spiral lamina and the scala tympani are not affected, but the rhizoid membrane gets displaced, thereby eating up on the space occupied by the scala vestibuli. So if it is more, if the scala media is still, it's expanded, but still lesser than the volume or the area occupied by the scala media vestibuli, it's grade 1. Here, what we find is that the saccule has enlarged, the utricle has enlarged, but still the area is less than 50%. It's beyond 30%, but less than 50%. Some even consider their confluence as a grade 1, which is by Barath and by Bernard, right? And finally, you have a situation where the scala media is grossly hydropic. There is significant displacement of the rhizoid membrane, and the scala vestibuli either becomes very narrow and sometimes even obliterated. On the other hand, in the vestibule, we can see that the saccule and the utricle occupy a large chunk of the vestibular volume. And in fact, in such a situation, what happens is that the perilymph is just visible as a ring-shaped a rim of hyperintensity around this complete hypointensity of the composite saccular utricular shadow. So this is what is being proposed by this group from Nagoya University. Okay, there's another proposal which says that because the saccule tends to be affected more in endolymphatic hydrops secondary to Meniere's disease, the saccular involvement being more than the utricle, so there is something called a saccular utricular in ratio inversion, or the Suri technique. So here what we would have is the saccule becoming more and more hydropic, but the utricle lesser. But in spite of that, the involvement of the entire vestibular compartment would be more compared to a normal patient. So this is called the Suri technique, or the saccular utricular ratio inversion technique. And it is also being advocated, or rather proposed, that or rather it is being mentioned that this is usually the case when the hearing loss in the patient has exceeded 40 decibels. Okay, so these are some of the other references that you have regarding the grading of Meniere's disease as far as their imaging is concerned. Bharat is after Naganava, it's Bharat who has proposed grade 1, 0, grade 1, and grade 2. But Banats and Kasarman, they've added a grade 1, a grade, I mean, they've actually added a grade 1 in between. So their gradation is 0, 1, 2, and 3. And because of paucity of time, I'm not going to get into those details. I've given you the basic idea, and our friends who are interested in knowing more about it can obviously look up these publications. Okay. Once again, so what Naganava and the group from Nagoya University has done is they've gone one step ahead, and they've come up with something that they're calling a hydrops image. Okay, it's an acronym. They've come up with something. It's a pretty complicated kind of imaging technology, but I'm sure it's much more easier for our radiologist friends to understand than someone like a greenhorn otologist like me. And they are calling it the hydrops image. Okay, these are some of the publications that have come in from the Nagoya University talking about the hydrops image. And what is the hydrops image? The hydrops is actually an acronym for hybrid of reversed image of positive endolymph signal and negative image of positive perilymph signal. Now we know that the endolymph, now positive in MR means hyperintense. Negative in MR means hypointense, and 0 in MR means isointense. So how is it? I have been mentioning the fact that endolymph is hypointense, which makes it a negative signal. So how is it that they are generating a positive signal from the endolymph? So what I have done is I have created a flow chart to give you an idea as to what exactly are they proposing. And apparently, as per these publications, their diagnosis of endolymphatic hydrops is the specificity and sensitivity is increasing with the use of this protocol. So the first and foremost thing that that the patient is subjected to, and mind you, the hydrops images can be acquired, can be assimilated. It's actually a reformatted assimilated image, and the MRI can be conducted both either with intravenous or with intratympanic gadolinium. So the first thing that the patient is subjected to a heavy T2 MR cysternography, and the idea of the cysternography is to get the entire volume of the otic capsule of the labyrinth, both perilymph and endolymph. Okay, on a T2 weighted image, both the endolymph and the perilymph, they appear, this is without contrast, they appear as hyperintense. So the idea is to get the complete volume of the cochlea and the vestibule with the semicircular canals from the through the heavy T2 MR cysternography. Following that, the patient is given gadolinium, and the patient is subjected to what was mentioned earlier, a heavy T2 weighted 3D flare protocol. And because of that, you have the normal view, that is endolymph hypointense, and that is a negative shadow, and perilymph hyperintense or a positive shadow. Now, as is mentioned here, the perilymph appears hyperintense. It's called the positive perilymph image, but the endolymph is obviously hypointense. Now, because the endolymph is hypointense and the surrounding bone is also either iso or hypointense, it's very difficult to separate the margin of the lymph containing cavity from the surrounding bone. So how would you try and mark your endolymphatic cavity? How would you come to the conclusion of a less than 30%, more than 30%, less than 50%, so on and so forth? So there is a very poor differentiation between the endolymph and the surrounding bone. So what is done is that another image, a series of images are acquired after inversion, after shortening the inversion time, which leads to the endolymph becoming hyper intense. Now the gadolinium becomes hyper intense and it's called a positive endolymph image, as was mentioned here in the acronym. And this finally helps us to separate the endolymph compartment from the surrounding bone. Mind you, this is only being done to separate it from the endolymphatic around compartment from the bone, not from the perilymphatic cavity. Once we have the margins of the hyper intense endolymphatic cavity, that image is reversed again to make the endolymph hypointense again. And finally, all this data, all these images are assimilated, reformatted, brought together so that you have an image wherein the endolymphatic cavity, though is hypointense, is better delineated, and the perilymphatic cavity is hyperintense, and therefore you are able to calculate the percentage of the dilatation of the endolymph containing cavity better, and that is finally called a hydrops image. I just hope that I've been able to sort of, with this flowchart, make you at least give you a basic idea as to what this hydrops images are. I would be very happy if we, all of us together, different parts of the world, can do multicentrically. We can perform these protocol and come to a conclusion as to the effectivity, the specificity, and the sensitivity of uh, the protocol being advocated. Okay, from Meniere's disease, let's move on to some more sinister pathologies. And I really don't need to discuss any of these patients besides complaining of otological symptoms, say for example, hearing loss, a gradual onset hearing loss, an asymmetrical hearing loss, a sudden onset hearing loss. They can always complain of both disequilibrium and ataxia. So I'm not going to really go into the details because there's one more interesting topic that I still have left to cover with you. At the same time, it's not always necessary that tumors as large as these are going to be responsible either for vertigo or for dizziness or for ataxia in a patient. This is a patient that I had seen way back in 2006, and a vestibular schwannoma as small as that was causing significant ataxia. Mind you, there was no rotatory vertigo. The patient was unstable while walking. There was a gait-related ataxia, and it was secondary to this small vestibular schwannoma in the right side internal auditory canal. At the other hand, another patient wherein you have a small vestibular schwannoma at the fundus, but there is gross involvement of the basal turn of the cochlea and also of the vestibule. So this patient too can complain of either form, either a disequilibrium or even ataxia. Now, this is the case I wish. This is the patient that I wish to discuss with all of you in a little more detail because. It's a rare case. Literature reports about 150, at least the English language literature reports only about 150 to 160 cases of this particular pathology. So it's a 41-year-old male that I had seen in the October of 2013 who was complaining of dizziness for 4 to 6 weeks. Initially, it was mainly on the right lateral position while lying down with fatigability, then more constant and with any head movement. There, the cranial nerve examination 3, 4, 6, 7 was never normal, and there was a very fine right beating nystagmus on right lateral gaze. The hearing evaluation was normal in October 13. The patient went in for the vestibular investigations. I do not have the details of the rest of the vestibular investigations via the head shake or the optokinetic or the rest of the protocol that we follow. But the final report I did not have access. I mean, I did not have personal access to a VNG machine at that point of time, and these investigations were conducted in a different center. So the report mentioned a right peripheral vestibular lesion. The SVV was reported as a compensated right peripheral vestibular lesion, and the V hit was a right anterior semicircular canal lesion. I asked the patient to undergo an MRI. I was not very happy solely on the basis of these investigations, but the patient refused to do an MRI in October 13. February 2014, the patient reports to me with a sudden onset altered hearing in the right ear for 1 week with tinnitus. The dizziness surprisingly had improved. The left ear, the pure tone levels on the left side were normal, but on the right side there was a moderately severe, predominantly near sensory neural loss with a 30 decibel airborne gap. This time I asked for an MRI, and this is what the MRI had thrown up. This is what the MRI threw up. Okay, there is a lesion here, which is in close proximity to the posterior semicircular canal, in close proximity to the posterior semicircular canal on the posterior face of the petrous bone. So I'm sure a lot of you have already have the diagnosis of, obviously compared to the other side. The area close to the posterior semicircular canal is normal. Let's first look into the various images, and then we'll talk about this is another image, and this is a post-contrast image, and you can see the lesion very clearly residing along the posterior face of the petrous bone, right? You can very clearly see it on the right side. You can see it here. Its close relationship to the posterior semicircular canal, and compare it to the left side, which appears normal. Okay, this is post-contrast. This is post-contrast. You can see the lateral sinus here, and you can see the tumoral lesion in this part of the petrous bone. Retrospectively, I asked for a CT scan because I knew what I probably thought I knew what I was dealing with, and I needed to see whether there was associated bone erosion or not. And bingo, it was there. You can see the lateral sinus here, and you can see the mass eroding into the surrounding bone. You can actually see the rim of calcification over here along the ridges, along the edges of the bone, along the edges of the lesion. So this is the posterior semicircular canal, and you can see the lesion. In fact, the lesion is actually peeping into the mastoid cavity on the right side. So this is post-contrast. You can see the lateral sinus post-contrast. I beg your pardon. Yeah. Okay, and finally a soft tissue window, which showed the lesion actually eroding the bone and the lesion peeping into the mastoid cavity. This is the coronal section. You can see the posterior semicircular canal, and you can see the vestibular aqueduct. Vestibular aqueduct on the left side, which is absolutely normal, but the vestibular aqueduct is eroded and it's occupied by a mass in close contact with the posterior semicircular canal. Okay, you can very clearly see the lesion on the right side. Right. I'll move a little faster. We probably have just less than 10 minutes left. Vestibular aqueduct on the left side, on the right side, vestibular aqueduct on the left side. Okay. So this was a case of an endolymphatic sac tumor. This is a case of an endolymphatic sac tumor, and as I had mentioned, there are only about 150 to 160 cases reported in the English language literature. And so I have just put in these slides to give you an idea to differentiate between an endolymphatic sac tumor and an enlarged endolymphatic sac, which has a much more smoother appearance. This is an enlarged endolymphatic sac on the left side. The smooth appearance is much more smoother, much more smoother compared to what we had seen here. Okay, compared to what we had seen here, this is a much more smoother appearance because endolymphatic sac tumors are low-grade adenocarcinomas, which are locally malignant, causing a lot of bone destruction. So these are a few cases of endolymphatic sac, enlarged endolymphatic sac. The purpose here is not to discuss enlargement of the endolymphatic sac. I presume you had a wonderful lecture from Dr. Gada about a few weeks ago on this topic. Naturally, the patient profile would be much different. A patient with enlarged endolymphatic sac would present with during childhood, early infancy, childhood, whereas this was a 41-year-old patient. So I'll quickly go through some facts about this uncommon tumor that I encountered during my clinical practice. It was actually reported way back in 1898 as an adenocarcinoma of the middle ear, which was actually corrected in 1989 by Hefner as an endolymphatic sac tumor. Now, the surprising part was that the patient was not willing to accept my diagnosis of an endolymphatic sac tumor probably because of its rarity. And so I sent these images to my professor, Professor Mario Sana in Italy, and also to Professor Anil Lalwani at Columbia University, and both concurred with the diagnosis that it was in fact a case of endolymphatic sac tumor. There are a few publications in literature, and you can go through them. I still have to come across a publication which mentions more than 154 cases. But the fact is that these patients can actually present with a sensorineural hearing loss. They can present with vertigo. They can present with tinnitus, and a very important presentation in these patients is the sudden onset loss of hearing. Now, the hearing loss, whether it is a gradual hearing loss or a sudden onset, it's been attributed to three reasons as far as this pathology is concerned. A, obviously, when the tumor becomes bigger, there is direct invasion into the otic capsule. B, because the tumor is arising from the endolymphatic sac, it is leading to a secondary hydrops. In fact, if you look at the literature which discusses this, and I have a few of them over here, endolymphatic, this is from Cleveland. I'm sorry, it's not 188, not 88 cases, 150 plus have been reported. This is, beg your pardon, this is from Cleveland. This is again from Group Audiologico, Professor Mario Sana. This is from UK, the Charing Cross Hospital, UK. This is from Poland. And I forget where is this from. And in fact, you can see it mentions very clearly mimicking Meniere's disease. So because of the secondary endolymphatic hydrops, a lot of these case reports that are mentioned in literature, the patients were treated for endolymphatic hydrops, Meniere's disease, and later on it was diagnosed as a case of endolymphatic sac tumor. In fact, one or two cases have also landed up. I mean, have landed up the patients to the ENT specialists' offices with features of otorrhea, chronic suppurative otitis media, and it was during the course of investigation that it was diagnosed to be endolymphatic sac tumor. So do read up those publications if you can. And there's a very, very strong association of von Hippel-Lindau disease with endolymphatic sac tumor. The presence of endolymphatic sac tumor in VHL is about 11 to 15%. So any patient of von Hippel-Lindau, and I beg your pardon, I forgot the third reason, and that is for hearing loss in a patient with endolymphatic sac tumor, especially the sudden onset variety, is an intralabyrinthine hemorrhage. So the patients with endolymphatic sac tumor who have an intralabyrinthine hemorrhage actually present with a sudden onset nerve loss. Okay. Anyway, so von Hippel-Lindau. So these are some facts about von Hippel-Lindau. I'll just rush through because I need to show you. And this is the differential for as far as the diagnosis, the clinical diagnosis, the radiological diagnosis is concerned. But as far as the histological diagnosis is concerned, there are some other pathologies that also have to be kept in mind. And this is what hemorrhagic labyrinthitis, obviously this is not secondary to an endolymphatic sac tumor, but this is what a hemorrhagic labyrinthitis looks like. Normally on T1, the labyrinth is isointense, as you can see on the left side. As you can see on the left side, the labyrinth is isointense, but on T1 pre-contrast images, hemorrhagic labyrinth becomes hyper-intense. So this is what a hemorrhagic labyrinthitis looks like. So in case you are suspecting a hemorrhagic labyrinthitis, and also once you give contrast to the patient, there is not much of an increase in the hyperintensity of the hemorrhagic labyrinthitis. So finally, where we started off from, when to do, which to do, what to do. I hope by now you know why did I title my presentation as what to look for and then when to do, because it is your clinical acumen that decides A, when is it that you want to image the patient? Okay, so you have to be, I'm sure all of you are, would agree with the fact that once you know that this is what I am suspecting, that is when you decide whether I need to image. And naturally, if it's a bony component, a bony lesion or a bone erosion, or the bony compartment of the temporal bone that you're looking at, your CT scan becomes your obvious modality of choice. But the moment it's the soft tissue part, it's the intracranial part, then it becomes the MR. So there's no one size fits all. It's your clinical acumen. What's the clinical background of the patient? What's the presenting symptom? What's the clinical sign? What are the other bedside investigations and investigations throwing up? That is what will help you decide when to do it, which one to go in for, and what to look for. And there are scenarios wherein you might have to use both of them. Thank you very, very much for listening to me for the last 1.5 hours.
Thank you very much, Dr. Manoj. As usual, it's a wonderful presentation, very beneficial. We have one question for you.
Yes, sir.
First part from me. What about the CT negative? You have CT temporal bone can miss the perilymphatic fistula, or another way, could we have perilymphatic fistula with a normal CT temporal bone? So this is the first part of the question. Second part comes from Dr. Ines, that do you think that is a new technique, gadolinium-based technique used for Meniere's disease could be useful on those cases with CT with a clinical picture of perilymphatic fistula and the negative CT temporal bone?
The first question I did understand, Professor, and there are cases of microfissures which lead to perilymphatic fistula. Obviously, these patients will be CT negative, and probably some kind of an MR imaging modality would be helpful, and including the gadolinium would be helpful, because it could show us the percolation of the gadolinium from the perilymphatic fistula into the middle ear cavity or the hypotympanic cavity. So I hope that answers your question. But Professor, if you could repeat the second part of your question, please, again.
Do you think that is a new technique, gadolinium-based imaging from the Japanese group you highlighted in your lecture? Could be this is a good option to pick those cases with perilymphatic fistula and the negative CT temporal bone?
Absolutely, sir. Absolutely. Why not? See, the whole idea is that the perilymph is receiving the gadolinium, correct? The whole idea is that the perilymph is getting the gadolinium. So if there is a leak of perilymph, the gadolinium is also going to go wherever the perilymph goes. And we would have a hyper intense shadow similar to that of perilymph wherever we find perilymph either in the hypotympanum or in the middle ear cavity. So I hope it answers your question. But then this has to be subjected to more vigorous multicentric trial.
Okay, just probably one more question.
There could be some